everything had been changed. So I don't do now femto cataracts at all.
Yeah.
Unfortunately.
It's very difficult to be convinced by a machine that worth $500,000 to make rexes only, and
Yes.
And you are not. I don't know, Dr. Adai. I would like to know your opinion on this. You know, my father was a doctor also, and he was an internal medicine.
Sorry, I'll stop sharing until I make 3G, 4G. Okay.
And he always told me something that you cannot convince the patient with something that you are not. You yourself is not convinced with. It will appear on your face. So don't try to lie, because he will detect it. What do you do?
Very true.
You know, at the early days of the multifocality, when was when we used to, you remember the array lens of Allergan?
AMO array.
Yeah, we hit a record of removing.
Oh wow.
Video is excellent, Dr. Ahmed Masri.
Because it was not satisfactory. Well, it was actually we didn't know how to choose the patient. If you choose the patient right, you have a good patient with multifocal. If you don't, at that time I remember that Allergan gave us 25 lenses to make a study. And we removed 26. So the guy from Allergan came to visit us. How come I gave you 25 lenses and you removed 26? So I told him, simply because one of the patients heard that we are removing these lenses, and he was operated outside the hospital, and he came to join the number.
Dr. Ahmed, the video is going well or not?
لا دلوقتي كويس very reasonable طبعا.
افضل يا دكتور.
Because of Zoom.
Much better يا حاتم. Much better.
But you can do one thing in Zoom. If you go to the top right screen,
يا حاتم, do you hear, Doctor?
Hit the three dots, and then you can optimize video for Zoom.
Dear friends.
No, I didn't optimize it for Zoom. I don't know this. This
is a very important.
You have time. You have time. 15 minutes. You can do.
How can I optimize it for Zoom?
Make it 50%.
Look at your screen. The very top right corner, you'll see 3 dots. Dot, dot, dot.
Yes.
You touch that button. Click the button. And now look at the list, and one of them says
wait.
For video.
Where is it? No, I don't find it on the up screen. Oh, 3 dots, yes? Is it?
Yeah, on the Zoom.
Yes, optimize the screen for share for video clip.
Click that, and that's much better.
Optimize screen share for video clip. Okay?
Yes.
Always learning from you. Let's start.
This is the first trick for today.
The same video. There is difference.
Looks pretty good.
The quality is better, but the speed is slower. Take care. That's
no
what
problem
I see
about the speed, but the quality is good.
Yeah,
the quality is good.
Yeah,
the quality is good.
The quality, no problem. It is a slow speed. This area is slow speed. I am making slow move. Slow motion. Sorry. This is the usual. Okay, I think it's good.
Yeah, it's limited by your internet bandwidth.
It is 25 megabytes per second. It is the best in Egypt.
Okay, it's okay.
Now, excuse me. I will explain a little bit what should we have to do, because we are 4 minutes before 4. I will get your permission to ask the Orchidia. He will display his products in 3 minutes, not more. Okay. Then Professor Mahmoud will introduce our guest of honor, Professor Uday, and the other guests. Then I will tell the schedule. Then Dr. Uday will start his presentation. He will be the first and will be the last. That's okay?
Okay.
We have made him wake up very early, and this is, he's starting his day. We don't want to.
The difference is 9 hours. 9 hours between us and California.
Yes.
We should visit his place when we go to America next time.
Come anytime.
We always go to San Diego. Last year we were there.
No, come to Beverly Hills. Better.
And Beverly Hills as well. At 4 o'clock sharply, I will start the live streaming on YouTube, because there was a problem with Facebook from 3 accounts. That's why I resorted to Facebook, to YouTube, and from the YouTube I will put it everywhere, and it will be recorded and will be uploaded after being produced to your accounts. Okay, but now it will be live streaming on YouTube. And I will record it on 2 computers as well, in order to avoid any failures. That is usual for us, to be ready. Now we need only 2 minutes.
صباح الخير دكتور احمد، صباح الخير دكتور محمود، صباح الخير دكتور حاتم. انا محمود ابو ستيت اوركيدي. انا ممكن نكون اتقابلنا قبل كده. اهلا وسهلا. في اي حد عنده اي سؤال؟ اهلا، ازيك يا دكتور؟ اخبار حضرتك يا دكتور احمد؟
You can always talk in English, because we have our guests. He should understand. Otherwise, he will talk in different language. You not understand. No.
Hello. I'm Mahmoud Abu Steve from Orchidea Pharmaceutical. I'm asking if anyone has trouble with the connection, or anyone has trouble with getting familiar with Zoom meeting. So I'm here for any technical support. If anyone has any question regarding sharing screen, sharing videos, managing the webinar, you can get back to me anytime. We can talk in the chat box in order not to interrupt the meeting. As Dr. Muhammad said, we will start with a video for Orchidea. As a video time is 1.5 minutes exactly. It will start 4 o'clock and will end 4.1 minute later. The video explains the SDU new portfolio for Orchidea. Once it's ticking 4 o'clock, we will be live and the video will start. Then it will be followed by Dr. Mahmoud Ismail introducing all the panel. Then the mic go to Dr. Muhammad Al-Mahdi, and then to Dr. Oday.
No AL. AL is totally different. You will put me somewhere between the Gulf and the Iraq.
Okay, I got it. So
I hope I will be Mahdi. I wish.
I will click on the button right now. So we're going to be live.
Okay, now you are live on YouTube.
Okay.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Mahmoud. And today, باسم الجمعية الرمادية المصرية وجامعة الأزهر مئذنة الألف عام. We would like to welcome you today for the webinar. كل سنة وحضراتكم طيبين. We are honored to have distinguished guests today. But before, I would like to emphasize on something that probably Dr. Adai doesn't know. Couching technique for cataract surgery started here in Egypt 3,500 years ago with a same device that have moved to Spain 850 years ago. It was documented on the Cordoba Museum Al-Andalus in the south of Spain. Today we have distinguished guests. Our star, Professor Uday Divan. Professor Duvay, he is a clinical professor of ophthalmology in a very distinguished institute, Jules Stein Eye Institute. All of us, we have learned from this place. Oakland School and University. He hit a record of 4 times award winning. He is nationally recognized as an anterior segment surgeon. And of course, I would like to welcome my dear friend, a great professional from Egypt, Professor Ahmed Al-Masri, the head of department from Alexandria University, a distinguished anterior segment surgeon. Also, my dear friend, Professor Hatem Ammar, a distinguished professional in the anterior segment, professor and head of department, Sohag University. He is also a member of the Egyptian Board of Ophthalmology. And of course, my colleague, Professor Muhammad Mahdi, from our department, University of Al-Azhar. He's a senior consultant in anterior segments, specialized more in cataract and glaucoma surgery. He had his fellowship in Amsterdam University in Netherlands. And I would like to pass the word for him to start the schedule of the day. Dr. Muhammad, go ahead.
Okay. You exit your screen, please. The schedule for today, it will start with 5 talks. Each talk is 15 minutes. We will start with our guest of honor, Professor Uday. He will talk about approach to the white cataract, and we want to learn from him, followed by Professor Ahmed Al-Masri, who will talk about management of cataract in patients with keratoconus. Then Professor Hatem Ammar, who will talk about subluxated lens, one problem with different solutions and approaches, followed by me for managing ruptured posterior capsule during phaco. And the last one is Professor Uday as well, who will talk about IOL calculation, past, present, and future. Professor Uday, you are welcome.
Pleasure to have you, sir. Go ahead.
Go ahead. Honored to be here. Let me start our presentation. We have a nice new stuff for you today. Okay, we're looking good. So my talk is success with white cataracts. This is something that every ophthalmologist will see on a routine basis for the entirety of the career. So the main question you have to ask for white cataracts, number one, is there fluid from decomposed lens proteins in the capsular bag? That's the intumescent. Number two, is the nucleus dense or relatively soft? And 3, are there any associated abnormalities? So remember the color gradient. White cataracts can be just pure white, but they tend to be on either side of the spectrum, either slightly blue or slightly yellow. So this is examples of patients with a bluish tint to the cataracts. In picture A, you can look here and say, this cataract has that bluish tint. It's white, but has a bluish tint. In panel B, look at the patient. It's a young patient. Look at the eyelashes and eyebrows. But bilateral white cataracts, that's going to have a bluish tint as well. And then figure C and D also. The blue tint is a high risk for capsule splitting. This is the so-called Argentinian flag sign, because it looks like that flag after we stain with trypan blue. So we want to avoid this. Other cataracts may have a yellowish tint to them. So if you look at these, they're white cataracts, but there's a yellow or almost brownish coloring to them. And then sometimes they can be associated with other abnormalities. In frame A, there's a wrinkled and fibrotic lens capsule, and take note of the gap between the iris and the anterior lens capsule. In figure B, this is trauma causing a white cataract that's completely subluxed into the anterior chamber. In picture C, You can see absence of zonular support. And in picture D, this is associated with aniridia. So about half the clinic patients that we see have a dense cataract with the yellow whitish hue, and about half have a soft cataract with the blue whitish hue, and only about 1 out of 20 have unusual additional issues. So I have a brief video here. I've sped the video up so that we can watch it in its entirety. But the video is shown at a high speed. The most important thing is to avoid the capsular rhexis running out, the Argentine flag sign. So when you poke the lens capsule, you can see a lot of milk comes out. So we need to inject more viscoelastic. Notice that there's no main incision yet. This is the double capsular rhexis technique, making one small capsular rhexis through a small incision, a side port, a paracentesis, now rocking the nucleus and rotating it and releasing any fluid that's in there. So we decompress the capsular bag, we relieve that pressure gradient, and then the risk of run out is going to be very low. So again, now there's no pressure in the capsular bag anymore. You can also use a needle decompression technique, going in there with a 27 gauge needle on an empty syringe, poke the lens capsule and aspirate. But notice these are done with the eye full of viscoelastic and highly pressurized. You must have the pressure in the AC higher than the pressure in the capsular bag. So at this point, this resident can go ahead and make the main incision, and then we can start the regular capsular rhexis. This is a video of me guiding a junior resident to do the surgery. So this is a doctor in training with less than 100 cataracts of experience. So certainly if this doctor can do a beautiful job, that means just about anyone can. So there again, there's loosening of the nucleus, and now we need to create our normal 5 millimeter capsular rhexis. So refill the eye with any viscoelastic that was lost. We can use Van Ness scissors or other small instruments if we need to, or we can just grab or poke the capsule and then create the larger rhexis. So if you're going to deal with an intumescent white cataract, remember, you have to release that pressure. So either do this technique, which is the baby rhexis and then a double rhexis, or decompress the capsular bag using a 27 gauge needle. You can also use a $500,000 femtosecond laser, but that seems awfully expensive just to be able to do this one maneuver. So here's completion of the rhexis, and then the rest of this case is going to proceed normally. Let's move ahead a little bit here now. I have now an unusual case for you. So what is different about this white cataract? This is going to be a big surprise. Let's watch the video here. So as the video plays, there's the A scan we did ahead of time. Trypan blues instilled inside the eye. We'll put our viscoelastic here. That looks good. And there's the white lens capsule. And what's unusual is I'm making the main incision because the lens capsule is under zero pressure. It's very soft. The lens capsule is very soft. And then the anterior lens capsule is downwards. It's like a depression. So we're going to make a very important 5 millimeter capsular rhexis. Now this patient is a young patient, 45 years old, and she had a pars plana vitrectomy for retinal detachment 1 month ago. So you have to ask yourself, what would cause a white cataract, completely white, 1 month after a pars plana vitrectomy? And keep in mind, the retina specialist is a retina fellow who's still learning. So when you go in with a phaco probe, there goes the whole nucleus. So we knew this ahead of time. Look at the A scan. We could see that the posterior capsule was open and the lens material was already leaking into the vitreous cavity. So we knew that in the pre-op testing. So of course the lens has fallen all the way back. The patient suffered an injury to the posterior capsule at the time of the vitrectomy when the retina was repaired 1 month ago. So we'll clean up the anterior segment, let these pieces fall back into the vitreous, that's okay, or the vitreous cavity. The patient already had a full vitrectomy, so there's no actual vitreous left. And then it's very important that we made that 5 millimeter capsular rhexis because we're going to need to place a 3-piece lens in the sulcus with optic capture. So we'll advance here, fill the capsular bag, and let me show you how we put the lens in. So here comes the lens. You can see the eye is very soft. It's a unicameral eye. It's already had the vitrectomy. So we'll get the lens in the correct orientation. To make it easy, we'll put the entire lens on top of the iris initially and then dial it in exactly where we want it. So we'll get that lens inside there. We'll take that bubble out to make the video prettier, and then we'll dial it in, and it's going to be an optic capture. So the haptics are in the sulcus. The optic will go behind the anterior capsule like a button through a buttonhole. In doing this, we have no change in the IOL power calculations because the optic is still within the bag. Now we'll suture the incision shut, and of course, sitting right next to us is our friend, the retina specialist, and he will go ahead and remove this. And so he'll go do the pars plana lensectomy, take that out, and you can see here, there's the piece. It'll come out very easily, very easy washout. It's very soft. You don't even need the fragmentome. This lens material sucks down the port very simply. And that goes beautifully. Let me show you one last video. The last video is a routine case for me. That's my website, cataractcoach.com. Thank you guys for subscribing. There's a free email we send out, a new video every single day. So let's watch the last video. This is a routine white cataract. We see these commonly. But look what's different. If you look at the periphery of the lens nucleus, you can see there's a little bit of a red reflex. So in this case, it's all dense nuclear opacity, and we don't have any of the risk of the Argentinian flag sign because the lens cortex has not liquefied. So you see that gap there between the iris and the dense nucleus. That shows that the cortical area is actually quite clear. So we'll make our incision. And then my normal technique here is going to be that a 5mm capsulorhexis, I'll use just the forceps, and then we'll chop the nucleus with our phaco chopper. So white cataracts are important to understand that they're not all the same. There's a spectrum of difference between the types, and you have to know how to deal with all the types. For the bluish tint in the cataract, the soft white cataracts, the intumescent cataract, the risk is the Argentinian flag sign. For this cataract, we can chop it, split it. The nuclear density is quite good. This is not a very soft lens, and we're able to just chop it into pieces and remove it. So if you have a cataract with the yellow tones or brown colors in them, that's going to be more nuclear density, less likely for Argentinian flag sign, but more difficult to remove the nucleus, requiring a more chop technique and more ultrasonic time. And then we'll get to the end here, and then the case looks fine. We'll put our IOL in the eye. We have a whole set of white cataract videos on Cataract Coach, more than 30 of them, so you can certainly watch any of those. And then the rest of this case is normal. And let's see if we can advance. Here we go. And that is it. So done with my first talk. Thank you guys. I appreciate it.
Yeah, thank you, Professor Uday. Now it's time for discussion for 5 minutes. Dr. Mahmoud, do you want to ask something, or Dr. Masri?
Dr. Ahmed,
yes. Please go ahead.
No, please, Dr. Ahmed.
تفضل Dr. Mahmoud. تفضل.
What was the cause of the young bilateral white cataract? It was parasitic or inflammatory or something like this, the young adult that you have shown in the video?
A great question. That was acute onset type 2 diabetes. Very obese woman, had very high blood sugars, had blood sugars of 700-800, and then long-term. So hemoglobin A1C was 12 or 13, and she just had bilateral opacities from the diabetes.
Okay, I have a question. Yes, please. Thank you so much for this very nice presentation. I have some questions regarding the visco that you're using. Which type of visco that you prefer in the suspected cases of Argentina flag? Is it the visco cohesive or the visco dispersive?
Very good question. In most cases, I'll just use the dispersive. There is a benefit to doing a cohesive or super cohesive or maybe even a soft shell technique to really flatten the anterior lens capsule down. But because we're doing the opening of the lens capsule through just the small 1mm paracentesis, if I fill it very strongly with the dispersive viscoelastic, it won't escape from the eye. It'll maintain the pressure. So the answer is either is okay. The goal is maintain the anterior chamber pressure to keep the anterior lens capsule flattened. If you have a big incision, your main phaco incision, adding the cohesive or super cohesive would be helpful.
Okay, did you see the Argentina flag sign in non-white cataract?
I think we've seen the Argentine flag sign most commonly in the intumescent white cataract, but I don't think I've seen it in non-white cataracts.
I have a case, diabetic, young age, and I had Argentina flag in non-white cataract. Maybe, I don't know why. I don't know what's the explanation. Maybe it's what was the too much viscodispersive that I put for this patient. It may be the cause of pressurizing the anterior lens capsule, but I don't have any explanation for it up till now. It was a single case in my life. That's why I'm asking if anybody noticed Argentina flag sign in non-white cataract, regular cataract, posterior subcapsular one. Okay, thanks a lot.
Dr. Hatem,
Dr. Oday, thanks for your very great presentation, as usual. You agree with me that doing capsulorhexis in white cataract at risk of Argentina is better from the sideboard with microcapsulorhexis forceps than cystotome, as you can control it with microcapsulorhexis?
You're right. The microcapsulorhexis forceps have much more control. But the videos where my residents operate, we are at a charity hospital. The patients are getting free surgery, and those forceps are $1,000, $2,000. We don't have them. The needle.
Charity hospital in Beverly Hills?
No. So remember, I have a private clinic in Beverly Hills where we have everything. But then I also spend half my week teaching my residents in the charity hospital. Patients get free surgery, but the charity hospital cannot afford such fancy equipment.
That's good. One more question. If Argentina flag sign occurred with you, do you agree with me it is sometimes possible to turn every half of the anterior capsule into half rhexis and continue phacoemulsification as long as it is not that hard nucleus?
Yes, you can make one half and the other half like this, continue, but the goal is I would get the lens out of the bag, because any pressure on the bag, you try to extend it. You can extend it, but for sure.
The last question, I want to ask something.
Yes, there is a next question here that should we proceed with phaco?
Okay. We still have 1 minute. Okay.
Yes. Should we proceed with phaco or to convert to extra cap if you have Argentina flag?
I prefer to still stay with phaco. Bring the nucleus out of the capsular bag, put viscoelastic under it, re-protect the corneal endothelium, operate in the anterior chamber. The cornea will forgive you later. But I'd rather not make that very large incision, because then applying extra forces to get the nucleus out whole, you may split the capsular bag more.
Okay, is there time for another question, Dr. Muhammad, or to proceed for the next?
Professor Oday, in some cases of white cataract, especially the Morgagnyan ones, if we don't have enough viscoelastic and the milky material get in touch with the corneal endothelium, I see in some of the cases that the cornea get much inflamed. Do you think that this is something to do with the pH of this fluid?
I think it's probably because the lens proteins are protected. The immune system has never seen them. So any little bit of lens protein causes tremendous inflammation. So if you get that milk that's full of lens protein and you let it coat the endothelium, you're going to have a huge inflammatory response right on the delicate endothelium. So I think viscoelastic is very important. If you don't have it, try an air bubble or use a syringe to aspirate out the milky fluid in the Morgagnyan cataract. But that lens protein
should be completely evacuated and protected from the endothelium by viscoelastic. Now it is the turn for Professor Masri to present his talk.
Clear the screen now?
Yeah, still.
Go ahead. Go ahead? Okay, thank you so much. Yeah. Thanks again for inviting me to share with you this nice faculty and members who have a lot of interesting talks. And honestly, my talk is really, it's a hot topic. And I think most of us are touching this point It's less than 15 minutes. I'm going to talk about the management of cataract in patients with keratoconus. First of all of us know that the main problem is the intraocular lens calculation and the refractive outcomes in ectatic corneas in general. So just to simplify everything or the matter in general, I'm dividing it into three main pillars. We have three main pillars: the age of the patient, the stage of the keratoconus. Yes.
Screen not share.
Share screen, Dr. Ahmed.
Share.
Screen not share. طب ثانية
not share.
ثواني معلش. المفروض اطلع presentation.
That is usual.
Just 1 second.
No. Are you sharing now, Dr. Ahmed?
Yeah, that's it.
Okay.
Yes. 1 second, please. Yes. It's okay now?
Start from this first.
Okay.
Yeah.
It's okay now?
Yeah,
okay.
It's going
okay. Again, as I said, the main problem for the management of cataract in patients with keratoconus is the intraocular lens calculation and the outcomes, and in all ectatic corneas. So we have three main pillars: the age of the patient, the stage of the keratoconus, and the stability of the cornea. So depending on these three pillars, the age, whether young or middle-aged or old, the stage, whether mild, moderate, or severe, and the stability, whether it is a stable cornea or not stable cornea or unstable cornea. So to start with, in young patient with mild keratoconus and stable cornea, of course, tomography is mandatory for any patient who is going to do cataract with keratoconus. We depend on optical biometry, and depending on the third generation formulae, like the Haig's L, the Shammas, the Holiday 2, the Barrett, the Hill Asker's website, and all the results should be within 2 diopters of the Haig's L formula. 2 diopters for a patient with keratoconus is not a big deal, not like the other refractive outcomes aiming for the quarter or half a diopter. So we have to be very careful and to do more than one equation or more than one formula to get the best result. If the patient is still young with mild stage of keratoconus 1, for example, and with instability or unstable cornea, so the cornea is showing progression, we have, and all of us know the signs of progression of keratoconus, which is thinning of the cornea more than 10 microns per year, or increase of the curvature of the cornea more than 1 diopter per year, or increase in the difference between the superior and inferior meridian more than 1.5 diopters per year. In these cases, we have to stabilize the irregular cornea before doing the cataract surgery. So in these young patients with unstable cornea, all of us agree that corneal cross-linking is the main tool for halting the progression of keratoconus, and had been approved, of course, to be the main treatment for patients with unstable cornea or progressive keratoconus. These patients, I'm doing pinhole tests for them. If the vision improves, so I'm doing both cross-linking and rings at the same time. If the vision did not improve, I just do cross-linking. And in all cases, I'm waiting for 3 to 6 months after doing the cross-linking with or without the ICRs to take a dependable case to put in the formulae to have an acceptable result for the cataract and IOL. The process of the intercorneal segment and cross-linking is so simple. It doesn't need a learning curve, just the measurements, the nomogram, putting the ring in the femto tunnel, adjusting the Kerr ring, which is the one used now more than the Intex, having, depending on the nomogram, different sizes of the rings, And then after centralizing these rings, putting them in the correct position, depending on the nomogram, whether A, B, or C, I'm just removing the epithelium and starting the cross-linking at the same setting by putting the riboflavin and then the ultraviolet rays. So it's a combined cross-linking and ICRs at the same setting is my routine. And I know this is a debatable point, but this is my routine since more than 10 years now. If the patient is middle-aged with mild or moderate stable keratoconus, tomography again is mandatory, optical biometry, of course, and both the K readings of the pentacam and the IOL master or the lens star should be comparable, should be reasonable, should be in harmony, should be there no difference between both of them. And again, depending on the third generation formulae, the Higgs, L, Shammas, Barrett, or the Hills Asker's website. And here is a debatable point, which is the toric IOL. In my hands, the toric IOL predictability in irregular cornea, it does not have good results. You should have very stable cornea with very regular pentacam to put an IOL for a patient with keratoconus. But in an irregular cornea, the toric IOL is not designed for irregular cornea. So the results are unpredictable and the patient may be not satisfied. The surgery itself of doing cataract after cross-linking and ICRs, it's not a big deal. There are no ticks or tips in this cataract surgery. The usual capsulorhexis, the visualization is perfect, it's not bad. The cornea is clear, the subepithelial heads of the cross-linking does not bother you during working. The ICRs also, they don't bother you during working. Hydrodissection, viscodissection as usual. This case was, as I said before, young age, and the nucleus was soft, but and even the phaco technique was so simple with no hazards on the cornea, of course, protecting it with the soft shell technique, with the viscoelastic every now and then. Another small tips is before getting the phaco out, just insert viscoelastic to keep the pressure of the eye and to prevent posterior vitreous detachment. There is nothing abnormal for these cases. And of course, calculating the IOL, many of these cases are high myopes. So putting the IOL in the bag is mandatory after removal of the lens matter and the irrigation aspiration. So it's nothing abnormal in these cases, and the results are usually good as long as the biometry is taken correctly. Cleaning the posterior capsule, I'm putting usually the intraocular lens under irrigating solution and inserting the IOL inside the bag. As you see here, it is soft one because it was high myope, so it's mostly low power IOL. Again, going back to the main dilemma of the calculation, if the patient is middle age with severe keratoconus and it is stable, of course, all of us know that severe or advanced keratoconus means that the Ks are more than 64 diopters, with corneal thickness less than 400 microns and posterior floats more than 40 microns. Here, there is no other alternative than doing triple procedure, DALK, deep anterior lamellar keratoplasty with phaco and intraocular lens implantation. But if the patient has hydrops, you can do the manual DALK and phaco, or if there is scar, you can do the penetrating keratoplasty with cataract extraction and intraocular lens implantation. In cases of combined DALK and phaco emulsification, depend on the other eye's case. Yes, you can take the axial length from the eye with the problem, but the case you cannot depend in the advanced cases on this case. Or you can take a standard case to put in these cases. And here's an example of 2.5 minutes video showing the DALK procedure, because many surgeons think that doing DALK, leaving only the endothelium, will not withstand the phaco emulsification. As usual, after taking the 6 quadrants to take 80% of the depth of the stroma, there are different schools. I prefer to debulk the cornea first, going deep as much as we can, nearly the descent membrane. Everyone has his own school, doing the big bubble technique and being sure of the big bubble that it goes to the periphery with high pressure. The edges are well marked, and the best clue for having a nice big bubble is the bean-like air bubble which floats around the big bubble, having the brave slash and under the visco to prevent the escape of the air from inside. rapidly, and then going to the endothelium and to remove the stroma, having endothelium and only bare over the anterior chamber. Many of us may think it will be weak to withstand the phaco. No, it's strong enough to withstand the phaco technique with the patient inside the eye. The only problem is if you have a type 2 bubble. Here, definitely the type 2 bubble without the dual layer will not withstand the cataract extraction. Again, visualization is good, even without staining. Capsulorhexis with the microincision capsulorhexis forceps. It was soft irrigation aspiration, and then inserting the intraocular lens, taking a suture at the wound, and then continuing your DALC technique. Again, cleaning the posterior capsule, and then under visco here, I prefer to put after widening the incision, put the IOL in the bag and putting my cord to constrict the pupil to be sure that there is nothing entangled from the iris in the wound. And then preparing your DALC or the stroma, and after removal of the endothelium, and the case is finished with the regular sutures. So you can do the phaco with the big bubble technique. So in the old age, above the age of 60, with keratoconus, with mild or moderate stage of keratoconus and stable cornea, these cases usually in the old age are stable. So we can depend on these steep corneas up to 56 diopters. And we can depend on the readings of the pentacam and take the usual formula. But with moderate keratoconus, more than 57 diopters, up to 62 diopters, here we have to do the surgery in steps. What's meant by steps? First to remove the cataract or to put the zero IOL, and then to reassess the power needed, whether to put an add-on or an IOL after doing the surgery. It should be very well explained to the patient that the surgery mostly will be on steps. The first one is to remove the cataract, and then to assess the IOL needed. Why? Because in these cases, when you have steep corneas more than 57 diopters, you find the biometry is not acceptable, -17, -15, which is not the true biometry. And from my experience and from my colleagues' experience, that if you try to put any type of lens, -5, -7, you will find the patient again -10 and -15. So don't put an IOL. Wait for the patient who is aphakic or zero IOL, and then reassess after a few months. Mostly these patients will not need any more IOL to be added. Lastly, for old patients with advanced keratoconus and unstable, of course, we know the signs of advancement of having very thin pachymetry, less than 400 microns, with steep case, endothelial folds and hydrops and opaque apex, do the standard PKP and cataract and IOL. So the take-home message at the end is, number one, complete explanation to the patient by the situation. It is not an ordinary situation like any other cataract. No, it could be under 2 steps. You can, it could be not satisfactory for the patient as an outcome. He may have another procedure to do to have a good result, a good refractive result, or preoperative investigations should be done for the patient, pentacam, specular, manual case, and multiple calculation of IOLs with different formulae to have the one which is reasonable. All plans and tools to protect the cornea should be done during the surgery, and correlate the age with the stability and stage of keratoconus. Lastly, you have to give enough time for the compromised cornea to heal, which may take up to 2 or 3 months. So don't be astonished when you find that the result after the surgery +2 with -4. No, wait for a few months. The cornea will have its corneal memory and go back to normal, or to have an acceptable result. And thank you so much for your attention.
Thank you, Professor Ahmed, for this nice talk. I will start the question with taking 2 questions from the audience. Then I will go for the panelists. One of the audience was asking, how long can you wait before you're changing the IOL or implant a new IOL in the patient that you left aphakic?
3 months.
3 months.
At least 3 months. At least 3 months.
At least 3 months.
Yes.
What about the biometry in cases already have an ICRs? How did you do the biometry here?
Again, after waiting 3 to 6 months, the cornea is, we can depend on this cornea, and we can do the biometry depending on these corneas with the pentacam. So you have to correlate the case of both the pentacam and the lens star or eye master that should be near each other. And the stability of the cornea usually preferable even after 6 months, because these cases, as you know, or as you remember, already did cross-linking. So it's cross-linking and rings at the same setting. So you have to wait for at least 6 months. Like those are putting the ICL after the cross-linking, you should wait up to 1 year even. But after 6 months, you can depend on the case.
No, okay, thank you. The question now is for Dr. Devjan, if you have something to say. Dr. Uday?
Okay, just one remark, Dr. Mahdi. First of all, excellent presentation, Dr. Ahmed. الحقيقة, you have covered almost everything, and we don't. Just one remark: when you are doing phacoemulsification on bare desmids or dual layer, just keep putting some of the viscoelastic on top of it. It will help not pumping of the membrane. Each now and then it will pump up for you, and it just bothering you. And as you said, if you are type 2, you are more prone to rupture. Actually, this is, it's a challenging situation.
Very
but
difficult.
if you just put some viscoelastic, and I think it will work it out with giving it some time, slower techniques somehow, and you don't rush it. And it's very wise to wait 3 months, as Dr. Ahmed said. I was going to answer the question about how long you should wait before implanting an intraocular lens after leaving the patient aphakic. Actually, 3 months is at least, because you might be faced with removal of some of the sutures in cases of high astigmatism also. Let me remind you, removing of sutures always tends to myopic shift of the cornea. And that's why this is very wise to wait. If you have an IOL calculation preoperative -15 and -16, this is not realistic actually. And you will be faced with a aberrant IOL power at the end. So it's very wise to wait. And removal of some of the suture, this will change some of the astigmatism, and somehow it will influence the IOL calculation. Thank you. Dr. Hatem, I believe he has some question.
One question, Dr. Ahmed. If you are doing cross-linking with intracorneal ring segment in the same setting, you do cross-linking with Dresden protocol or accelerated protocols?
Accelerated cross-linking now. Yes, of course, I do agree that Dresden protocol is the best with the best results. But in our hands, it's more than 5 to 6 years, 7 years now, we're doing the accelerated epi off cross-linking, and it's nearly the same results.
And you can trust the stability after accelerated protocol after 3 to 6 months is sufficient. No need to wait for 1 year. And you don't examine anterior segment OCT to evaluate amount of haze and success of, you trust it completely after 3 to 6 months.
I'm doing routinely my anterior segment OCT for all the patients of cross-linking to see the haze and everything, and the depth of the cross-linking. And for the case, I can depend on them after 6 months.
You agree with me?
Not the refraction.
Okay, you agree with me that for every case with keratoconus, even I am trusting, you trust the formulas, there is a possibility for IOL exchange or add-on or something.
Sure, so you have to explain this to the patient. It should be explained clearly to the patient.
Like phaco after post-refractive corneal refractive surgery, I always give the patient a notation that maybe IOL exchange an option. We will evaluate it after time.
Yes, that's mandatory for these patients. Patients counseling is essential.
To be in the safe side.
Yes.
Thank you very much, Dr. Ahmed, for this nice presentation. Now it is the turn of Professor Ammar to talk about his subluxated lenses, not one lens.
Okay.
Lenses. His subluxated lenses.
There is many lenses. Many thanks, Dr. Mohammed Mahdi. Many thanks, my mentor, Dr. Mahmoud Ismail. He is my mentor. He's with Dr. Ahmed Masri. Here I am with 3 mentors, 2 Egyptian and 1 international. Really, I am following the cataract coach think long period. Let's start. You see lens subluxation. Okay. Lens subluxation, one problem with different solutions, financial disclosure, no financial interest. Unfortunately, there are many forms of lens subluxation by many types, many shapes, many causes. Pseudoexfoliation, trauma, Marfan syndrome, high myopia, hypermature cataract, iatrogenic. And surgically, I classified into mild zonular instability, less than 4 hours, 4 o'clock hours, or mild generalized zonular weakness like mild phacodenesis, slight lens movement during anterior capsulorhexis, wrinkling of the capsule during capsulorhexis. It is a very important sign. When you are making capsulorhexis, sometimes it wrinkles or move the whole lens. It is suspicious of weak zonules. Or pseudoexfoliation with mild floppy capsular band. This is all mild cases of zonular instability, but severe zonular instability is more than this. Really, surgical treatment of subluxated lens is still at present a real challenge to any surgeon, whatever his experience. We need many tools. You must have Sayoni, you must have capsular hooks, Ahmed segment. This is capsular tension rings. This is Sayoni and double eyelet, Sayoni, 9O Prolene. You must have many tools. And unfortunately, it is classified into 2 types. It is intraoperative accidental subluxation. Any case of cataract, sometimes complications occur inside the case. Like this routine case, hard cataract, everyday practice in Upper Egypt, routine capsulorhexis after staining, phacoemulsification. I am fan of divide and conquer technique still up till now. I know it is not the era nowadays, but I love divide and conquer and make well in my hands. Take care when you are working, when you see something like this clearing. This area is suspicious. When you see red reflex enhanced a little bit, it is suspicious in this area. So must keep anterior chamber pressurize it, inject dispersive OVD, viscoat. I prefer viscoat if you don't have it. I have no financial interest. You can inject methylcellulose. This is zonular dialysis, about 3 o'clock hours in this area. I'll continue here to inject OVD over the time and phacoemulsify the nucleus. It is away from the battle area of emulsification. It is on the side. Keep the cannula of the viscoat in the anterior chamber and use it as a spatula to manipulate the particles and keep injecting OVD all the time. As long as you are injecting dispersive OVD, vitreous will not prolapse as long as there is a stable anterior chamber without loss of the pressure in the eye. Here, this is the opening, I think. Inject OVD before coming out. Now you have this area of zonular dialysis. Inject viscoelastic, form the bag. You will see it. Right here, it's going back. You can, in this condition, I take the decision to implant capsule tension ring to support the capsular bag in place and be in the safe side. Sometimes you can make use of 3-piece IOL with putting the haptic in the area of the dialysis. It will be sufficient, but I prefer to be in the safe side always. I am a little bit conservative. Remove the lens particles by simple expression, then implant single piece, multi-piece as you like, no problem. Any IOL, I hear single piece hydrophobic acrylic IOL in the bag, as long as it is well supported by the capsule tension ring. Sometimes here you will find iatrogenic zonular dialysis after capsulorhexis, groove, removing the nucleus particles, routine phaco and a grade 3 nucleus hardness, not that hard. Removing the part, taking your time. Everything is okay, nothing is problematic at all. But take care in this point. While removing the epinucleus, no problem up till now. Now, take care. Oh, this is the whole capsular bag. Take care in the slow motion. I repeat it in slow motion. The whole capsular bag is coming to my hands, as you see. This is the capsular bag coming with the epinucleus. That's sure I did bad hydrodissection from the start. Keep anterior chamber, pressurize it, inject OVD. This area, the decision is in this condition, as you will see here, inject the OVD. Pupil is a little bit narrow, so I inject adrenaline by a special cannula directed to the iris. Decision is to insert capsule tension ring in the bag now with all this lens matter. The rule is to insert the capsule tension ring as late and safe as possible. In this condition, no time to wait to remove the epinucleus because it is attached to the capsule. You must support it at first, although removing the cortex will be a little bit difficult, but you can finish and manage it easily and safely with a little bit time of concentration, but never allow the anterior chamber to collapse, even after implanting capsule tension ring. You can finish the case safely, implanting single piece hydrophobic acrylic in the bag, my routine IOL. As you see here, there is lens matter. You can remove it even after implantation of the IOL in the presence of CTR, no problem. And you will see the case second day. I inject air here for documentation for the second day to see for photography second day. You will find everything is okay 1 day post-operative without any problem. Rounded tuber reactive, no problem at all. Pre-operative subluxation is usually more severe, so you will notice it, but you usually prepared well for it. This case of child 15 years old with traumatic severe subluxation, more than 5 hours here, but after dilation, you'll find it more than 6 hours. This is the area of cellular dialysis decision. Here, when you start to make capsulorhexis, start away from the area. Take care, the whole crystalline lens is shifted toward the other side. Use microcapsulorhexis for forceps. I am a fan of the micro forceps, really. It gives you good control of the capsulorhexis. Then you will support the bag by capsular hooks to support it. 2 capsular hooks in the area of dialysis. In this case, you must take your time. Don't hurry because this case need more time than routine cases to get a good result. Now, the decision is to implant Sayoni ring, creating the Hoffman pocket, to loading the 9 oprolim in the whole of the Sayoni. Then insertion of the Sayoni ring in the capsular bag. Moving it to the area of dialysis. Again, is the Hoffman pocket and area of lens subluxation. Then your sutures, first tightening them, IOL in position, well positioned, everything is going well. Well centered IOL in place. Everything is okay. Sometimes things more severe trauma, severe dialysis, and vitreous loss after repair of ruptured globe. This case is done in the university hospital, so some of the facilities are not present. Something like Charity Hospital. OVD injection to push the vitreous back. The problem here is long-standing. After 4 months of the repair of the large ruptured globe, the capsule, there is some areas of fibrosis. Capsulorhexis will be a little bit be difficult. I started to make capsulorhexis. Usually with the, I never see Argentina flag with the microrhexis forceps, really. Thanks God. At this point, there is area of calcification. We can't continue the capsulorhexis, so I decided to change the plan. Irrigation aspiration, removing the lens matter like envelope technique formerly used in the extracapsular to make benefit of the red reflex. This is, I loaded the Sayoni segment, Sayoni ring, loaded it with 9 oproline. Then come back to the capsulorhexis to cut it by manually with forceps and the scissor in the same time to have a well sharp edge. Always I try to keep the capsular bag, especially in young age, to help in prevention of uveitis and reaction and UGH syndrome. I find it's a great help. Then insertion of the Sayoni ring with positioning of it in place. manipulate it from the hole. Sure, the hole must be above the edge of the capsulorhexis. This is routine in every case we use in Sioni ring. It's well positioned. Creating Hoffman pocket. Sorry, the video here is not that good because it is recorded in the free hospital. Loading the needles, the straight needle is okay. For and threading it to the insulin syringe. The other needle, I surprised it is a small one rounded, so I flattened it, planted it into the insulin syringe, but it will be lost. So I supported it with a spatula to direct it to reach out. You must modify your techniques according to the available somewhat time, but you finish the case nice. Suture, tightening it to ensure its position well. Then, planting the IOL in the bag. No need. I here evaluated the iris. Is it possible to repair it or not? I find there is a large area of lost iris. It is not safe to take a suture in it. So I decided to make use of the scar which is present from the previous operation, and don't polish the anterior capsule in the area where deficient iris. So you'll find it post-operative. Sure, you must close it with suture. He is a child. 2 weeks post-operative, you will find the area of the eye capsule which you doesn't clean it now is opaque. It is nearly completing the effect of the iris without the patient complaining of any dazzling or problem with the light. This is more advanced case with neglected trauma with a scarred capsule. This is the last case. Dr. Mohammed Mahdi, don't worry.
Yeah, don't worry. You still have.
That's okay. Inject OVD, dispersive. I am a fan of the dispersive in these areas. It is good job. Here, staining of the capsule, trying to make capsulorhexis to implant my Sioni. Using my capsulorhexis microforceps. Hard, so I used micro scissor, venous scissor, not micro, main incision, it is venous. Then continue, alternate many times of alternation between capsulorhexis, scissor, here by manual, handling the anterior capsule, trying to cut it to micro scissor, hoping to have finally a well-formed capsular bag to implant my Sioni here. Here I used the cutter as IA cut and cut IA. Here during dealing with the lens, I use IA cut, no cutting as aspiration. Area of vitreous loss, any clearance, I do cutting. Here I IA cut IA, I make use of it. Always pressurize the eyeball, remove the lens, then evaluate the capsular bag. Unfortunately, after all this effort, I find the bag is not suitable for implanting anything. It have no edge. This area is interrupted. So I decided here to change the plan completely to plan C, not B, to remove the whole capsular bag and implant iris glow lens. As long as you will implant iris glow, you must clean the bag well, remove any parts of it, then inject my cool using the same special type of cannula directed downward, then implanting my iris glow lens, whatever the type, aphakic iris glow lens, to be supported by the iris.
Wise decision.
Inclination of the iris. Don't forget to do peripheral iridectomy. It is a must. Irrigation aspiration, removing the OVD, and the case ends safely. So, to take home message, when dealing with lens subluxation, you should always be ready with high index of suspicions, different strategies, different standby tools, so you can get the best results. Thank you.
Thank you, Professor Hatem, for this nice presentation. Now I think we should have got the full range of cataract from the California one by Dr. Uday to Alex one by Dr. Al-Masri, and the hardest and is the South Egyptian ones near to Central Africa. Now I will go to the middle ones in Cairo.
دكتور محمد طبعا يعني اولا thank you دكتور حاتم for this nice presentation. According to the time schedule, I think we still have about 2 minutes to have some questions. Dr. Hatem, there's a question saying, is there a direction of the capsular tension ring while you are inserting depending on the zonular dehiscence, or you just put the capsular tension ring as it is? From the audience. You got the question?
Again, I didn't hear.
Is there any specific direction depending on the zonular dehiscence to put your CTR?
Yes.
Or you put it regularly in one direction?
The ideal is start 180 degrees from the area of dialysis. So the maximum convexity will be in the area of dialysis. Usually when implanting the CTR, you implant it, the ends will be in the area of insertion. So I start against the area of dialysis to make sure that the maximum convexity with the maximum support will be in the area of subluxation. Sometimes you can't do this. So you must rotate it at the end.
Perfect. The last question is, in the case of the university, but it's also from the audience.
Yes.
لحضرتك دكتور حاتم, you use the Sayoni ring without prior insertion ring of a CTR. Why?
Sayoni ring is like, my colleague may be he is misunderstanding. Sayoni ring is different from Ahmed segment. Sayoni, it is like CTR with either one or two eyelets, one side or two sides. So it gives the effect of capsule tension ring, and in the same time you can make a stitch in it. You bust a 9-oproline stitch in it. He is maybe conflicted with using CTR with Ahmed segment. No, in the university I use Sayoni, not Ahmed segment. So no need to CTR.
Tamam. Any question from the panelists?
Yes, Dr. Ahmed, once again, thank you, Dr. Hatem. It's a very nice presentation. In the last case, which is very challenging, actually, do you like to make 1 point scleral fixation in a case like this? As a start, you were not. I understand from the video that you were prepared for everything because you had your iris glue at your hand because you were prepared. You knew that you will do anything to solve the case.
Everything is possible in a case like this.
Yeah, in a case like this, on all trauma, subluxation is very eminent. Do you like to make 1 point scleral fixation, or you prefer
you 1 point scleral fixation and the other in the bag?
In the bag, yeah.
When I find, really in my hands, I find that when the bag is not present with circular edge, I prefer to remove it.
To remove it and you go for another way.
Clean everything and not either double flanged technique, which I am not well trained in it up till now, but hoping to be with Yamani technique. I prefer here in iris glue lens. I find it's working better and easier in my hands.
This is true as long as you have good iris and regular pupils.
Yes, and you have it closed, and you have it. The pupil went meiotic very easily.
No, not very easy. I injected my colso. Yes, I am in the safe side. No vitreous, sure, no vitreous. It is narrow pupil. Now I can do it safely.
Dr. Udaid, do you like to add something? Do you use the iris glue frequently, or you prefer the Yamani technique?
In the USA, iris claw lens is not available.
It's not licensed there.
Yeah, it's not FDA approved. So for us, you can do an AC lens, angle supported, but I'd rather do sutured in lens. So either Gore-Tex or Yamane.
Scleral fixation or Yamani technique.
Right.
Okay.
I have a question for Dr. Hatem.
Okay.
Is there any chance to implant the capsule tension ring in cases while you are not sure that the posterior capsule is completely intact?
I never implant capsule tension ring in any case with anterior or posterior capsule not intact. Whether any one of them, either it is not complete or the posterior. I find it enlarge it and giving you unpredictable effect.
If you have a traumatic cataract and you are not sure about the status of the posterior capsule and you have to implant the lens prior to removing the lens material, Are you going to implant the ring, or
No.
you should wait?
I will never do anything without being sure it is in the safe side. Safety is first. Being a little bit later in implantation of the capsule tension ring with a slow manipulation, then if I find the posterior capsule intact, I implant the CTR.
Professor, something.
Yeah, excellent points. I agree. One trick we also use is we'll place a suture through the eyelet of the CTR,
yes.
Then implant it, and the suture is outside the eye. And if everything goes great, we just pull the suture, take it out. If there's a problem, we can pull both ends of the suture and remove the
good idea.
That's very good trick.
That's very nice. Yeah.
Nice. Okay, for the sake of time, we should move. Dr. Mahmoud, في حاجة عايز تقولها حضرتك بس؟
No, I'm just saying simple, very simple maneuver, and it's worthy.
Thank you so much.
We can forward.
It's my honor to introduce Dr. Mohammed Mahdi, Professor of Ophthalmology at Al-Azhar University. Dr. Mohammed هيكلمنا على management of rupture posterior capsule during phaco. اتفضل.
Okay, I'm starting now. At the beginning, I'm going to welcome Dr. Uday again for being with us in this nice topics. And also I would like to congratulate all of you for this nice presentation. Now it is my turn to present about management of posterior capsular rupture during phaco with or without vitreous loss. The problem here is that broken capsule and vitreous loss is inevitable and could occur even with the best experienced surgeon who could have it at a rate of 0.5%. And a beginning resident could have up to 15% posterior capsular rupture without vitreous loss in about 15% of cases. So the challenge of cataract surgery is to minimize the risk of complications and to optimally manage complications that do occur. Okay. Intraoperative complications is a wide range, but part of it is the broken capsule and the vitreous loss, in addition to the other items that's clear here, but it is beyond the scope of this meeting. The sequelae of vitreous prolapse is so many, and it is also beyond the scope of this. So in case of cataract surgery, we should have our alternatives before we start surgery, as Dr. Ammar did. He has all the alternative for the case, and he brought the iris claw lens for this particular case. That's why he succeeded to pass through it. So we should be ready before starting with the alternative procedure and to diagnose the case well and able to prevent the occurrence of complication by following the rules, as Dr. Uday always said. And we should have an eagle's eye to early recognize the potential problems and respond as early as possible with the actual management plan. So be ready before you start. The well-prepared surgeon anticipates the potential problem cases as the whole list that we have it here, and think that very few cases escape this list. So we are always working with the problematic cases. Prepare a mental flow chart of maneuvers and sequence of decision before entering the patient's eye, and keep the required instruments on standby mode, not in the next door. There's a saying that an ounce of prevention is worth a pound of cure. We should realize that each step of cataract surgery is built on a solid foundation of prior maneuver. That's why prevention of complication is very important. Prevention of complication starts from anesthesia to wound construction to avoid minimal wound leak and to enable stable anterior chamber and two tight wounds and revision of the tubing of the machine, phaco-fluidic understanding, anticipating borzonial integrity operatively, and be prepared with the techniques to minimize the general stress. Also, during capsulorhexis, utilizing a different viscoelastics to flatten the lens dome during capsulorhexis and improve visualization as necessary in cases of mature cataract or hypermature using trepamplo. Hydrodissection, proper hydrodissection, hydrolineation, and the mobility of the lens nucleus should be ensured before starting phaco. which might be difficult in some cases. During phaco, you should always keep and limit emulsification only to the safe zone, which is within the center of the pupil, away from the cornea, and little bit away from the posterior capsule. During phaco, don't jump and remove the epinucleus. Epinucleus is gentle, soft, and protective. Don't remove it before complete removal of the nuclear material. Remove the subincisional cortex first and keep the capsular bag always sufficiently concave with viscoelastic to avoid snagging the posterior capsule and injuring it or disinserting the proximal zonules. Early recognition, the index of suspicion must be high to appreciate the early signs of complication and allow optimum corrective actions. Something subtle like the bouncing of the iris diaphragm and changing the anterior chamber depth or changing the pupil size is sometimes an early signs of broken capsule with redistribution of fluids in the posterior segment. A reliable sign that vitreous is present is loss of flowability of the lens material into the phaco handpiece or during aspiration. That's why we should stop aspiration and discontinue phaco, because vitreous cannot be phacoed. Tilting of the lens equator and loss of the ability to rotate the nucleus at any stage or deepening of the anterior segment are ominous signs of impending loss of the lens material into the posterior segment. These signs deserve immediate attention. And by keeping this video is one of my earliest cases. I think it was in the early 2000s, something like that, 2002. And I was lucky to have ruptured posterior capsule in both eyes of this patient. And the whole lens was completely displaced posteriorly. And I was lucky enough that I succeeded to get it out because I was doing some posterior segment work at the time. Early recognition, a peaked pupil or movement of the pupil edge with remote touch is a classic sign not to be ignored that vitreous is there. Early response. Early response, this means that it is not the quickest, it is the calmest. Control your innate withdrawal response on recognition of the problem. Go to foot pedal 0 and maintain the anterior chamber irrigation. Remove the dominant hand instrument, inject viscoelastic through the sideboard, remove the phaco tape with the anterior chamber completely full to avoid anterior chamber collapse. With the incision effectively closed and the condition static, now it is time to assess the situation, inspect, relax, and think, and to announce the exact situation to your staff. Remember to relax your voice and be calm. And once complication identified, the staff should be able to spring into action and prepare well-rehearsed plan. The vitrector should be seamlessly assembled in these cases. Vitrectomy kits is a long list with alternative implants, as Dr. Ammar did. Then more than enough viscoelastic is very important with this whole list. The actual management plan depends on if you need enough extra anesthesia, damage control by compartmentalization with viscoelastic, remove the prolapsed vitreous, remove remaining nucleus material, manage posterior dislocated lens. I will start with the first case to demonstrate what I said earlier. The first case, it was a straightforward case during phaco. I noticed something, it will pop up here. I did complete a nice rhexis using the bent tip of the insulin syringe. I did hydrodissection through the sideboards here. Then during the sculpting here, you see in this area, it will come in a slow motion now. See this part. I saw there's something shining here. I think that it was my fault. I went so deep in this area. Okay, I kept this one in mind. I kept skeptical all over the maneuver and very gentle. Sorry, sorry. Okay, then I rotated the nucleus, then I divided the nucleus, I removed the complete nuclear fragment. Okay, then after completely removing the nuclear fragment, we could observe that there's a break in the posterior capsule, which is a limited hole here. I re-injected viscoelastic, then I pushed the vitreous posteriorly, then I tried to do irrigation aspiration of the cortical material. I removed it. I started always from the areas away from the troubleshooting holes. Then the last one to play with is this area. You could see here that there's a hole and some of the fluids escape through this hole into the vitreous. You see this is the hole here. Now I will remove the remaining cortical material after injecting more and more viscoelastic in order not to have any vitreous here. But during the last part of the vitreous, I kept the anterior chamber and the capsular bag inflated. Then I used the manual cannula and inserted from this side port to get this part aspirated. As you can see here, always keep in your mind that keeping the bag completely inflated pushes the vitreous back and keep the hole limited. Now, the case is about to finish, and I'm inserting the capsule, the IOL in the bag without any vitreous loss in this case. Now I'm coming to the next case, which is a moderate posterior capsule rupture during quadrant removal. I always stain the anterior capsule with trypan blue. I do my rexes in the regular manner, the usual manner here. Then I remove some of the cortex. Then I'm doing the first trench, and I divided the nucleus into 2 halves. Then I rotate the nucleus. Then I'm trying to divide the first half into 2 quadrants. Then something happened here. This sudden loss of pressure in the anterior chamber and the collapse of the anterior chamber. At this part, I stopped here. I should freeze all my procedure. I keep the phaco handpiece inside, escape with the second handpiece, keep irrigation, and review the problem. Then I inject viscoelastic through the side port till I fill the anterior chamber completely. I inflate the bag. Then I remove the phaco. Then I am removing now, but after revision situation, I'm removing the cortical material. After removal of the cortical material, I found that there's a capsular rent here. I re-inflated the bag with viscoelastic. Then I aspirated the cortical material. As you can see here, no vitreous, so everything should come easy. If there's vitreous, nothing should come in, and will be demonstrated later. Here I'm removing the part next to the problematic area, but of course I don't know exactly the extent of the posterior capsular tear here, which is. Then I did anterior vitrectomy, and of course, ideally, I should have a 3-piece IOL, foldable IOL, because I have enough capsular remnant to implant on the sulcus, but there was no 3-piece. I implanted the MA lens. The last case will be this case with large capsular rent early before removal of any nuclear material. And it demonstrates a lot of science. Note here that this difficulty in rotating the nucleus, and I think this vigorous maneuver is the one who made the problem. That's why we should have an eagle's eye to observe what's going on. Now I'm trying to divide the nucleus. It is difficult because this quadrant is going a little bit posterior. Then while I'm trying to remove this quadrant, I see there's something is bouncing here, you know, nothing is coming to the board, and it is bouncing here. You see, it is and the posterior capsule. There's a big rent. I expect there's a big rent. I kept inside the anterior chamber, keeping irrigation. Then I inserted the cannula through the sideboard, injected viscoelastic to push the vitreous back as much as possible and to push the lens material anterior into the anterior chamber. Then I manipulated the lens material using the Sense keyhole into an area where I can do phaco, and I am removing the lens material using the phaco. No anterior vitrectomy had been done yet. I'm always compartmentalizing the anterior and posterior chamber using the viscoelastic, and I'm rotating the lens material on a support of the cannula with viscoelastic. Then I completely remove this one. Then a small piece will still here. I have to inject viscoelastic behind it to push it anteriorly as possible, and to change my hand and put this cannula from the other side. As you could see here, then I'm phaco this part. After this, I completely remove the nuclear material without any loss of any particle into the vitreous cavity. I stained the prolapsed vitreous with triamcinolone. Then I removed it with proper anterior vitrectomy. Now I'm exploring the capsular bag for integrity. Where should I implant? Now I see that the capsular bag, the anterior capsular bag is complete, and you could implant any lens on it, 3-piece or BMA. I inserted a BMA lens here, and you could see that here there's no red reflex because there is a big rent and the triamcinolone escaped posteriorly. Now I'm going to, this is the last slide for me. Here is Professor Ahmed Al-Masri in Berlin, I think it was 2000. And this is George Waring III and Professor Ahmed Shamma and Professor Osama Ibrahim and Bassam Al-Qadi and me. I was the youngest here. Okay, thank you very much for your kind care.
Yay, this is a fantastic talk.
Thank you, Dr. Muhammad. Thank you very much.
Thank you,
Dr. Adai, would you like to comment on anything, or we proceed for your anyone?
A beautiful talk. I think one of the most important points you mentioned is that we say in America, viscoelastic is cheaper than vitreous. Better to use more viscoelastic.
Yes.
It is much cheaper. Actually, it's much cheaper.
Much cheaper. Dr. Muhammad and Dr. Adai, also the question for both of you. Do you believe in the viscodissection? I usually do viscodissection before starting my phaco as a protection for the posterior capsule, minimizing the size of the nucleus, facilitating the rotation of the nucleus. What do you think about the viscodissection after the hydrodissection?
I'm going to tell something. Early during my course of learning phaco, I learned it from the CDs of the American Academy, from Howard Fine and Howard Gamble specifically, and Richard McCall. I learned it from the CDs. Then when I'm trying to implant, I have a problem with the grouping. I went to India, to Shroff's Eye Hospital, where I did exactly where should I start. Since that time, I'm always following the exact maneuver. Stains anterior capsule, whatever, is it clear or not? There's a good reflex or not? Use copious amount of viscoelastic. Do proper hydrodissection. After hydrodissection, I should try to rotate the nucleus to ensure that it is rotating. But of course, one of the vigorous maneuver has this inserted the posterior capsule here. And I never used viscodissection primarily, but I did it sometimes if I have some of the epinuclear material and I know exactly, because the amount of viscoelastic might be larger than the water. But nowadays, I'm doing some of the technique. I'm not inserting, I'm trying it now. I'm just doing the hydrodissection, not by insertion of the cannula under the capsular, the anterior capsule, but injecting a jet of fluid while I'm in the anterior capsule continuously before reaching the edge of the capsule. And it succeeds to do good hydrodissection without putting the cannula under the anterior capsule.
Thank you, Dr. Adai.
Okay.
I don't routinely do viscodissection. So for routine cataracts, 99% of the time, just hydrodissection. In unusual cases, posterior polars, things like this, Then we'll do viscodissection.
Then you can do.
I agree with Dr. Oday. I do only viscodissection in case of cerebropolar cataract after removing the nucleus. Remove the nucleus by after make hydrodelineation, nucleus removal, then epinucleus viscodissection. This is my routine.
My routine is doing viscodissection for all the cases. It minimizes the nucleus, it facilitates the rotation. And even if the nucleus is soft, I'm doing visco division. I'm putting the visco inside the middle of the nucleus, and it could be divided into two parts that will facilitate doing the phacoemulsification. Of course, again, I consider visco as my third hand. So usually injecting the visco under the capsule to disassemble the epinucleus and protect the posterior capsule facilitates a lot the surgery.
Actually, Dr. Ahmed, viscodissection was in the old days when I learned the phaco from Professor Jorge Alió at that time in Spain in the 90s. Viscodissection was a very important and crucial step, because at that time, if you remember, the knowledge and the red reflex, the microscopes, they weren't so efficient like the red reflex that we have nowadays in our microscope. So viscodissection was a very important step actually, at that time.
Thank you.
Dr. Mahdi, you want to say something or proceed?
One question to Dr. Mahdi?
Yeah, okay, go.
Go ahead.
In case of suspected rupture posterior capsule and vitreous loss, you routinely inject triamcinolone to stain the capsule, the vitreous, or you don't need it? Is always needed?
Actually, as you see here, if you don't have too much vitreous in the anterior chamber, there's no need to inject triamcinolone, as it might escape to the posterior segment and compromise the reflex, as you could see here. But of course, the most important here is that it was a big, very large or near total posterior capsular loss. But if I injected triamcinolone, it should be a small amount and not to inject hardly, not to push it posteriorly, above the iris and in multiple places. But I will add something for hydrodissection also. I want to comment. In case of posterior polar cataract or posterior capsular cataracts, I always do multiple location of hydrodissection without complete hydrodissection from one side.
Yes.
Yeah, I go from superior, I mean from the main incision, and then from the sideboards. And after this, with each one, I try to manipulate the nucleus a little bit, except in case of posterior polar cataract, which is impossible. If I did this one, I could disinsert the posterior capsule at the site of the sticky posterior pole.
Thank you.
Okay.
Thank you.
Dr. Adai, do you like to proceed? Do you have another presentation?
Yes.
Do it.
Please, Dr. Adai.
Okay, ready to go. My talk is the future of lens calculations. So we know these old generations of lens calcs. There's the first generation, which is just the old SRK formula. Don't use that one. Second generation is the SRK2. Don't use that either. Third generation is SRKT. T stands for theoretical. Holiday 1, Hoffer Q. Those use the K and axial length only to determine the effective lens position. Then there's the fourth generation, Holiday 2, Haggis, Olson, Barrett Universal 2. Those are better at predicting the effective lens position, but they require additional data like anterior chamber depth, white to white, lens thickness, refraction, etc. But remember, all of these formulas are static. Anytime there's any sort of new factor, they have to devise a new formula. Static versus evolving. So again, the Virgin formulas, including Barrett Universal 2, are static, ray tracing is static. There's some artificial formulas like Hill RBF that are evolving, but they have a limited backbone. And then combination is the one I've been working on for 20 years, the lattice super formula. And I'll tell you about that. The static formula works very well, but the problem is they require thousands of eyes for validation studies. Machine learned formula are limited in their data sets and they don't have a backbone. So what we do is we combine them. Right now, any surgeon can get about 80% accuracy within 0.5 diopters of the predicted refraction with any of these modern formulas. But that means 1 out of 5 are misses. It's a refractive miss. So if you're not happy with this 80%, we need to move on. 25 years ago, this study came out that showed that different formulas tended to work better in different axial length ranges. So each formula can have what's called a sweet spot. Here was a great study coming out of 8,000 eyes that showed that you could get 75% of eyes within a half diopter of target by using different formulas. So we decided that in 2015 that we can make a graphic 3-dimensional graphing and a super formula to incorporate the previous ones. So this was the original 1.0. We don't use this anymore. We've since evolved. But if you look at the graph, we have IOL power going up and down, and then axial length and corneal power. And you can see this is not a flat plane. It has a shape to it. And in different parts of the graph, different formulas are used to make it a little more accurate. If we look at Barrett Universal 2, and we have 1 million eyes of data for Barrett Universal 2. But if you look, just this is 60,000 eyes at various axial lengths. And if you look at the 60,000 eyes, you can see that Barrett also does the same thing, that at a different axial length, shown here with the arrows, he changes the formula, the different way of calculating it. So that's commonly done. We can compare the old Lattice 1.0 versus the Barrett Universal 2, and you can see when you overlay them, they're very similar, almost the same. This was a fantastic paper that came out recently, 2018, with Jack Holliday, and it looked at the formulas and their accuracy. Now, the Lattice super formula was not tested here. This is the most important graph of the whole talk. Remember this. All formulas are accurate and great if the axial length is average. So look here, 24 millimeter axial length with this blue arrow, all the formulas are right on target. But when you go over to the right here to 28 millimeter axial length, myopic eyes, now you can see that they're not as accurate. And same when you go to short eyes. So at average axial length, all formulas work great. The ones in the dotted line are the Wang-Koch adjustment for the myopic eyes. Now let's look here on the left for keratometry. If the K value is 44, wow, all the formulas work pretty well. And what's the one standout on the left graph? The black line is SRKT. If the Ks are unusual, the SRKT is going to be off. And on the right is the anterior chamber depth. With the AC depth, you can see if you have an average AC depth of 3.2 millimeters, well, all the formulas work well. But when you're not average, then they don't. So you say, well, I'm a good surgeon. I adjust and I hone my A constant. But that doesn't make sense anymore. That was great for 20 years ago. But honing the A constant doesn't make sense now. Here's why. When you change the A constant, all you do is you move the whole graph up or down. But that doesn't make sense. You can't treat all eyes the same. So just changing the 1A constant is not actually sufficient. It's what people do because they don't know, but it's not correct. Look at the graph again. If I had a very short eye in yellow, short eye with a steep cornea, and I have on the other patient has a long eye, very myopic, flat cornea, you cannot treat those two eyes the same. You know that. You can't do the surgery the same way, and you can't do the lens calculation the same way. And that's what's important here. So here's an example of me and my data. So this is from IOLcalc.com, which is free for everyone to use. On IOLcalc.com, the blue dots here are some of my very short eyes, axial length of 21 millimeters or less. And when I plot them out here, I realize that I need to change my graph. and I change it to become more accurate. So now you can imagine, to get the best accuracy, you have to change this graph in all different dimensions. Here's a graph. We call this the Manhattan graph because it looks like the skyline of Manhattan, New York. These are a bunch of my eyes. And you can see I have a lot of average eyes, but then I have eyes that are outliers, very unusual. Well, the nice point is, instead of honing one A constant, what we do is I hone my lens calculations for 10 ranges of axial length, for 10 ranges of keratometry, and for 10 ranges of AC depth. So 10 by 10 by 10 is my method will optimize for 1,000 points in a matrix. And now tell me, do you still want to try just hone one single A constant? Of course not. And then the beauty is I can optimize for all surgeons in the library, for multiple surgeons in my group, or just for me, so I can use just my own data. But what's helpful is if you look where the yellow arrow is, if I have a very unusual eye with a crazy measurements, and I don't have enough of my own patients, I can use the group data, crowdsourced data from our entire library. So let's talk about artificial intelligence now, because this is what we pivoted to 5 years ago. Who is the best chess grandmaster of all time? Well, it used to be Kasparov and Fischer, but then it became IBM Deep Blue. You may not remember because time flies here. 23 years ago, IBM Deep Blue computer beat Kasparov in chess. 23. What was your cell phone like 23 years ago, your mobile phone? Things advance a lot. Now, Google AlphaZero 2017, it'll teach itself chess in 4 hours, and it will beat any human 100% of the time. And they've applied this now to other games, Chinese Go or backgammon or whatever other game you want. You can't beat the AI. So here's a good example. This is a surgeon who gave me his eyes to examine. Using Barrett or our old original formula, about 80% eyes are accurate. But if I used his own data and then applied our AI algorithm to the calculations, I gave him 94% accuracy. That's a huge improvement. So we input all the posterior K, the axial length, anything we want to. Any future variable can also be inputted. And then we output it an adjustment with the AI. This is our formula, the lattice formula 2.0 AI. With a few hundred eyes, it itself predicted the Wang-Koch axial length adjustment. If you look at that big yellow bar across the screen on the bottom here, that yellow area is where the computer says these eyes need adjusting. And guess what? That's exactly the Wang-Koch adjustment. So if you agree with me that highly myopic eyes need to be adjusted, well, the same thing applies for highly hyperopic eyes, or flat cornea or steep cornea, or deep AC or shallow AC. You say, are 100 eyes enough to make adjustments? And the answer is yes. The lens you use today, that A constant that the manufacturer told you, was based on 20 eyes. Sam Maskett came up with a regression and adjustment for LASIK on 30 eyes. Wolfgang Hages, who died 6 months ago, he adjusted his formula to develop the post-refractive Hages L based on 40 eyes. And the Wang-Koch adjustment was based on less than 100 eyes. So here's a good example of a real-life surgeon. This is a doctor here in Florida, a friend of mine. He gave me 140 eyes of data. And like I told you, I now can give him his own personal AI calculator that tracks his patients and produces 94, now 95% accuracy. If you want this, we'll give it to you for free. You give us 100 or more eyes of very clean data from your own clinic. We'll construct an artificial intelligence calculator tailored to you for free. But you say, but I like Barrett, I like Holiday, I want to stick with them. Okay. Can you use AI with your favorite formulas? So what we made something we call Plus. So this is a universal artificial intelligence algorithm for lens calcs that can be applied to any formula. So we can start with Barrett Universal 2, and we can apply our artificial intelligence. And now we've got Barrett Plus, Holiday Plus, Haggis Plus, SRKT Plus, whatever you want. As a result, we can increase accuracy. I can take Barrett from 80% accuracy to 94, 95%. Same with Holiday, same with Haggis. Then finally, I want to leave you with one very interesting, neat development. That's the self-calibrating, automatically evolving ocular biometer. So you know about an optical biometer. You have an IOL master, a lens star, some other device. And you also know in your clinic, you have a wavefront analyzer for higher order aberrations. You have an autorefractor. We've combined them. So we use the biometer to measure the eye. And you get the K, the axial length, anterior chamber depth, whatever else you want. Automatically, that's submitted to the cloud for our deep learning artificial intelligence lens calculations. We then tell you, hey, put in this lens power, 21.5. You do the surgery. 1 month after surgery, your technician, not even you, your technician puts the patient back on the same machine, which measures the eye again, including the wavefront analysis and the autorefractor. The machine then sends back the data to our computers. So now we have the post-op outcome. And then we optimize the algorithm to make it even more accurate. All this happens automatically. No spreadsheets, no Excel sheets, no looking up in the chart. It's all automatic. No data entry at all. So this self-calibrating biometer, this machine is automated and objective data, millions of eyes, integrated artificial intelligence lens calculations, tailored to each individual surgeon, and it constantly evolves in perpetuity, forever. So I think the future lens calcs is using artificial intelligence and our method, this one called Plus. So it's a novel methodology to refine lens calcs. You can use it with any formula or approach, and the number of input variables can be added and weighted appropriately in the future. What if you say in the future, I want to start including posterior K values that I measure on my Galilei, or you want to include an equatorial lens position, or you want to measure an aphakic refraction, like in professor's eyes of the keratoconus, and you leave them aphakic. All this is possible. So the beauty is this evolves and improves forever. So my take-home point is you can be stuck with 80%, or you can evolve with AI. Now it's totally free and push to 95% accuracy. Thank you, guys. I want to thank, we have a big group here, and I want to thank you.
Thank you very much, Dr. Adai. It's very excellent, and the conclusion is amazing, actually. Dr. Ahmed, any questions?
For me, I'm so happy with the presentation,
Satisfied.
and yes, really, it was very illustrative. And I'd like to know more about this, and we'll re-listen to the presentation later on, and we'll be in contact with Dr. Adai, of course, because the entrance of the artificial intelligence in our field now, not only in the biometry, but also in the keratoconus and diabetic retinopathy, will make a big revolution for ophthalmology. Thank you so much, Dr. Adai.
There is a question from one of the audience. A question for Dr. Adai is asking what chopper you routinely use, please. He wants the routine chopper that you are using, Dr. Adai, because if he buys this chopper, he definitely gets a good result. So he is asking to get this one.
I'm happy to tell you. I'll put a link here in the chat box, which will show my instruments. I have to be very important to tell you that it's more important to have good hands and a good technique than the instruments. There's a saying, a good carpenter never blames his tools. A good carpenter can operate with any instrument. So there's the link of my instruments. I don't have a financial interest. It's made by Bausch & Lomb. It has my name, Dev Gen Chopper. But if you give me anyone's chopper, I'll still do a beautiful surgery. So don't be too reliant on the instruments. That's like the young kids wanting to buy these special Adidas so they can be better at playing football.
Yeah. we can score more goals. Yes,
Right.
Dr. Mahdi.
Yeah, I think that with this nice presentation, and I think that we kept Professor Uday at the beginning, at the last, it was our luck that he has such a kind of informative presentation at the last. And with this meeting, I think we summarize the different grades of cataract from California, Alex, Cairo, South Egypt.
South of Egypt, and Dr. Hatem, South of Egypt.
Of course. And I think that each one of us had presented some of the tricks that we should be ready before to start with. And we should neglect that to be ready as early as possible. As Dr. Hatem did, he arranged for another lens because he might need it.
Yeah.
Our problem comes from improper planning. This is the value of this meeting, I think.
Dr. Hatem, you have a last
I want
comment.
to thank all of you for this kind webinar, and Dr. Mahmoud Ismail, Dr. Muhammad Mahdi, Dr. Ahmad Nasi, and sure Dr. Uday. But one last question to Dr. Uday. You really use this type of artificial intelligence in your clinic?
Every patient.
Every patient.
Every patient.
It needs, what's the connection between the machines? I have IOL Master, I have autorefractometer. This is software or this is website to upload things in it, or I want to clarify this point, please.
For now, we have a website. We have a website, which I put here in the link, iolcalc.com. It's there in the chat box.
in the chat box. Okay.
In the chat box, yeah, Dr.
Yes,
Hatem.
yes. Okay. iolcalc.box. Okay.
This, you can sign up and do free lens calculations on your mobile phone or on your computer. If you have a Hogstrite lens star, we can connect directly to your machine. It'll automatically upload the data for us. Then the IOL Master is locked, and Zeiss won't allow us to do this, but we are in talks right now to license our product to them. We will see. The new machine, which is this one machine that self-calibrates and measures the patient, that's in development. That we don't have available yet, but that's being developed right now with one of the big companies.
Okay, so I can try this software and deal with it like, website, like dealing with finding my surgery-induced astigmatism.
Right.
Yes.
So go to the site, everything. You have to sign up, we'll give you an account. It'll allow you to track your eyes. So it'll save all your data.
Okay.
And then it'll apply the AI, the artificial intelligence, to your eyes, and then give you more and more accurate lens calcs.
I'll start immediately after the end of COVID-19 and find patients. Nowadays, you are working in webinars only.
Yeah.
No cataract anymore. Only webinars.
Unfortunately, only.
I think.
Thank you.
One last thing. Remember, for the young surgeons who are in the audience, myopia is a gift.
Yeah.
If you have any questions,
I can tell you about this because I don't need reading glasses.
No.
I'm like you. I'm -1.
I am -1. That's it. That's the best.
Lens calculations. If there's any doubt, don't aim for plano. Add a half diopter.
For myopic, sure.
Dr. Ahmed wants to say something. Yes.
Yes, there's a question from the audience. What's your preferable equation or formula for patients of radial keratotomy?
For radial keratotomy, I have a whole category on my website. I'll tell you how to do the calculations here. I'll put a link up. But that's a complicated thing, and I have many ways of doing it. And I've got in here in Los Angeles, I do 2 or 3 radial keratotomy patients a week. So at least 150 a year. And so I've done
the average results.
Yeah, so I sent a link. That's how to do it.
Yeah.
May I add something?
Post-operative refraction in these cases, you find it well with radial keratotomy with different calculations or not? You find refractive surprises or not?
They have a higher likelihood of refractive surprises. You certainly don't use the regular lens calculations, otherwise they'll end up hyperopic. So you need to add more power to the eye.
More likely hyperopics, yes.
Right. But I sent a link here. I explain all my things there, everything. No secrets. The idea behind Cataract Code, what I learned in the last 25 years, all the secrets, I'm giving them away for free to everyone.
That's the good news.
Thank you. Really, cataract.coach.com is a very valuable website. I think it is a must for every ophthalmic surgeon. Many thanks for it, Dr. Uday. Really.
Thank you, guys.
Excuse me. May I add something? I think I'm familiar a little bit with this kind of models and designing in my thesis during my PhD. I think that for most of our problematic cases, no formula should fit all. I think if we have a case with problems and it is outside the normal range, either from the keratometric reading or the anterior chamber depth or the axial length, we should submit it to different measurement and different equations, because everyone depends on a regression model and regression analysis which might fit in this one. And I think that the true in between, not in one. Do you agree, Dr. Uday, with that? Or
for sure, there's no one size fits all.
Yeah,
no. We have one size fits most, but
yes,
not all.
Yeah, that's true. So in case of trouble cases, we have to submit it to different measurements techniques.
Okay.
Yeah, and then I always like myopia, because if the patient ends up -1 and they don't appreciate it, I have an excimer laser right there.
Yes.
I'm making plano.
Yes.
Right.
We have to wrap it up, and we thank you very much, Dr. Uday. Thank you, Professor Ahmed Al-Masri. Thank you, Professor Hatem Ammar from Sohag, and from Alexandria University, Professor Ahmed Al-Masri. It was a pleasure to have you, Dr. Uday. This is not the last time. This is the first time with us, and we appreciate your effort, and we are looking forward for more and more collaboration. Thank you, Professor Muhammad Mahdi, for organizing this. Thank you very much, Orchidia, for
thank you so much.
Thank you.
Thank you.
Have a nice time.
Happy iftar and happy Eid. Happy iftar and happy Eid. Thank you.
Thank you.
Thank you.
Thank you, Muhammad.
ألف شكر. شكرا جزيلا. مع السلامة.
شاكرين لأوركيديا.
شكرا للجميع.
Thank you, guys. Next time it has to be in person. I have to come to Egypt.
Yeah,
Sure, waiting for you.
Waiting for physical meeting.
Physical meetings.
Will
be our honor.
I'll bring my wife for vacation.
Yeah.
Okay.
Always welcome.
More than welcome.
Once flight returning, we are waiting for you at any time.
Anytime you should be here. Yeah.
You are more than
so
welcome.
Much.
Thank you. Thank you.
Thank you, Dr. Uday.
Bye bye.
See you. Bye bye.
شاكرين دكتور حاتم باشا.
شكرا جزيلا.
شاكرين أستاذنا الكبير.
شكرا جزيلا دكتور محمد. ألف شكر.
شكرا ألف شكر. شكرا أوي.
تفضل.
شكرا دكتور محمد. شكرا دكتور أحمد.
شكرا محمود أبو سيد. شكرا جزيلا.
مشكور والله.
ألف شكر. شكرا جزيلا يا جماعة. ألف شكر. السلام عليكم.
عندنا بقى مسجلة بقى ونرفعها تاني من أول وجديد بعد
إن شاء الله بإذن الله.
إن شاء الله بإذن الله.
شكرا. أنا شيرتها على اليوتيوب حتى على كل المجموعات اللي أنا أعرفها دلوقتي.
تمام، الله ينور. ربنا يخليك. شكرا دكتور محمد. السلام عليكم.
مع السلامة يا دكتور. مع السلامة.
يا أبو حميد. محمد.
العفو يا دكتور. العفو يا دكتور على إيه؟ مع حضرتك تمام. لا.
أنا شيرتها على الفيسبوك وشيرت اليوتيوب دلوقتي على كل حتة، بس ما أعرفش فور هاو لونج تو ستي. إحنا بنحب الحاجة دي تبقى متسجلة وتتحط للأبد على النت.
هو أنا هعملها مونتاج وننزلها. طيب أنا بس هقفل اللايف.
اقفل يا باشا، متشكر.
أوكي.